Bismillahirrahmanirrahim. My topic is ventricular ectopy and when to ablate. Sequence would be a brief overview of ectopy followed by discussion of cases. Ventricular ectopy is one of the most common arrhythmia in daily clinical practice. At cellular level, ventricular myocytes spontaneously depolarize to create an extrasystole which is out of sync with the cardiac cycle. Symptoms are variable. Many patients are asymptomatic, and some described as palpitations, as fluttering, pounding sensations, skip beats, feeling of thickness, shortness of breath, or change in stamina. Post-PVC beat may cause some sort of chest discomfort. Patient may present with presyncope or syncope. These are the features of considered as non-benign PVCs. If patient is having underlying structural heart disease, if there is late gadolinium enhancement on CMR, PVC burden more than 10%, wider QRS duration more than 140 milliseconds, multiple morphologies of PVCs, atypical sites of origin means outflow tract VPCs are considered as typical sites of origin, and if outflow tract if origin is from non-outflow tract, then it's considered as atypical site of origin. If the ectopy has a short coupling interval, these patients can have RNT phenomena, and if the ectopy originates from epicardial site. Then there is a term called PVC-induced cardiomyopathy. It's a presence of LV dysfunction with PVCs, and there is no alternate cause of, especially if PVCs antedate the LV dysfunction. Then there is a term PVC-aggravated cardiomyopathy. These patients with a pre-existing cardiomyopathy can have worsening LV dysfunction with ventricular ectopy. LGE on CMR is usually not seen in patients with PVC-induced cardiomyopathy, but there is more obvious scarring in patients with PVC's aggravated cardiomyopathy. Then question comes, what predisposes some patients to have a cardiomyopathy and not others? These are the features. The burden of PVCs is one of the most important risk factor. Then duration of QRS complex, if it's more than 140 milliseconds, epicardial origin of the PVCs, the duration for which PVCs have been present, interpolated PVCs, asymptomatic status of PVCs, as these may go unrecognized and untreated, male sex, and lack of circadian variability. Then what are the indications of for ablation? Frequent PVCs, usually more than 20%, are believed to be causing or worsening LV dysfunction. PVCs that cause life-altering symptoms, PVCs that initiate VTVF, and frequent enough to reduce pacing from CRT. Then comes my first case. It was a 10-year-old child presented with palpitations associated with dizziness since 2018. This was his ECG, almost non-sustained VT. Echo in 2018 was normal. In 2019, the burden was 28.8%. This burden was 52% on Holter done in March 22. EF was slightly reduced to 45%. He had 2 episodes of palpitations followed by syncope during school time in May 22. Despite on beta blockers, previously flecainide was also tried in these patients, but with no benefit. Considering the patient's clinical condition and PVC is refractory to medical treatment, ablation was planned. This was his ECG just before the procedure, runs of VT. This is JL 3.5 to mark the left main stem, ablation catheter, and one catheter was placed in CS coronary sinus. Ectopy was mapped at left coronary cusp. And here ablation was applied, and within few seconds ectopy was disappeared, and this was his post-procedure ECG. Holter was done for 24 hours. Post-procedure, there was not a single ectopy. Then my case number 2, a 34-year-old male presented with palpitations and dyspnea with class 2 and 3, despite on medical treatment. This was his 12-lead ECG. His EF was 32%. There was a global hypokinesia of LV. Coronaries were normal. Ectopy burden was 31.5%. Inferior axis with LBB-like morphology with transition at V3, likely focus was in LVOT. Again, in this patient also, the ectopy focus was located, mapped at left coronary cusp. The earliest signals was achieved at this site. Ablation was applied at this site, and there was no VPC after the ablation. Post-procedure, Holter showed 0.3% of ectopy. Now, this is my case number 3. A 33-year-old male came for evaluation of symptomatic PVCs while on medical treatment. Ectopy burden was 29.9%. LBB-like morphology with transition in V4, likely focus was on RVOT side, right side. If the transition is before V in V1, V2, the focus we predict on left side, V3 some sort of borderline, V4, and after V4 then comes on right side. Ectopy was mapped and located in right side RV. Since the catheter was not stable, we used long sheath to stabilize the catheter, and ectopy was mapped at RV free wall. This was the site of ablation, and after ablation there was no ectopy. Again, 24 hours Holter, after the procedure there was no VPCs. My case number 4 is 36-year-old male with no comorbids, presented with palpitations with dyspnea. This was his 12 lead ECG. Ectopy burden was 23%. This was pre-procedure 12 lead ECG. Inferior axis LBB-like morphology with transition in V4. Again, the focus comes on likely on right side, and focus was mapped and located at RVOT site. This was the site of ablation, and ectopy was disappeared. I did not use 3D mapping or any other gadgetry in these patients, just simple conventional EP procedure. My case number 5, a 20 years old male with palpitations associated with dyspnea despite on medical treatment. Echo was normal. Two Holter showed burden was 33 and 30%. CMR showed normal sized chambers with reduced LV function. EF was around 48%. Superior axis LBB-like morphology with small or deep S in V4 to V6. Again, the likely focus is on right side. Ectopy was again located and mapped on RV. Earlier signals was 34 milliseconds ahead of QRS complex. In this case, we use the Carter system. You can see the location of the ectopy is originating from RV at this site, and it is being spread throughout the myocardium. Ablation was applied at this site, and the ectopy was disappeared. Isolated monomorphic PVCs without structural heart disease are generally considered as benign. Frequent VPCs can cause reversible cardiomyopathy. Short coupled PVCs can trigger VF. Beta blockers are first line but have low efficacy. Catheter ablation and antiarrhythmic drugs are reasonable to suppress PVCs, but if these don't work, then ablation is often curative. ICDs are reasonable in patients at high risk of sudden cardiac death. Thank you.
Thank you, Dr. Shabbir, for an insightful talk. My next speaker is the first doctor in Pakistan to clear FCPS cardiac electrophysiology. He has had advanced fellowship in cardiac electrophysiology from Taiwan, and currently is working as assistant professor of cardiology at Hayatabad Medical Complex, Peshawar. His talk topic is cryoablation in paroxysmal atrial fibrillation. Please welcome Dr. Zahoor Ahmed Khan.